If you're planning to apply for EM training in the UK, these are some hard truths that, in my opinion, you should know about before getting into the specialty. As an ED trainee, these are some things that I've come to realize after starting training. Now, this video is not made for the purposes of putting you off. It's just so that you understand what you might face during your specialty training and how to overcome them. So in today's video, we'll talk about 4 hard truths about EM training and how to overcome them. So why do I think that this is important to talk about? Unfortunately, even though I've only been in training for 2 years, I've come across a lot of colleagues who've had to quit because they either were no longer able to take the pressures of the training program, or they actually found out that they prefer other training programs and are now switching. So it's important for you to know if this EM training is actually the right one for you, if it suits your interests, and if it also suits your current life situations, and how to overcome some of these difficulties so that you don't end up leaving the program. Knowing about these difficulties also helps you to be a bit more strategic about your portfolio, so you don't have to sort of have longer time in training or repeat some parts of it, and obviously that contributes to making you less likely to continue in training. So trying to avoid these things, and these are the steps that we're going to talk about in the video. Knowing about some of these hard truths will also help you plan your portfolio better, and it will minimize the time that you work on certain things, buy you some time, reduce the pressure that is on you, and thus is more likely to allow you to progress in training without the risk of burnout. The first hard truth is that EM training actually requires you to go the extra mile. Now, not to say that this is specific to EM training, it's potentially becoming more of an issue even in other specialties, but just given the nature of EM training, it is a mix of both knowledge and skills, and the skills that are required of you, especially in the first couple of years in training, are hard to come by. Patients who come and require these skills to be done on them are not happening very often, okay? So that's part of the issue. Another part of the issue is that you're not the only person who's having to do these skills and achieve competency in these skills. You have higher trainees, you've got trust grade doctors who work in the department for a very long time, and they also need to do these skills. Now, I have to emphasize an important point here. I'm not saying that this is correct. I'm just giving you the actual facts. The fact is that you are having to compete with others in order to get these skills done. Now, if it becomes a really pressing issue, you should still talk to your supervisor. If you notice that all the opportunities are being given to trust grades rather than trainees, and it's not just a one-off, then do let your supervisor know, because at the end of the day, you are the trainee, and the faculty and the hospital has to be looking after you and not others. This is also not to say that people who work in the department should not have a chance, but it's a case by case, and if you're somebody who's still requiring to do that particular skill, then you should be prioritized. From your side, why might this be a problem for you? Because if you don't get the skills that are required of you done, you're going to feel under a lot of stress, because you might think that you'll progress in your ARCP, so that's one issue. Another issue is that it might leave you with a little bit of lacking confidence in carrying out this skill, because technical skills are all about muscle memory and repetition. And what this contributes is later down the line, when you're in higher training, you might feel like you lack confidence in that particular skill. If it accumulates over multiple skills along with knowledge issues, this can contribute to a feeling of frustration when you're in higher training and an increased risk of burnout. So, in order to avoid such a problem, what are some things that you are able to do to increase your chances that you get the skills done in the first couple of years of EM training? First of all, you have to seek opportunities outside the department. I'll give you a few examples. For example, chest drains can sometimes be done in pulmonary clinics. If you talk to the medical team and initially just highlight your interest in getting chest drains done, first maybe to have a look and see how it's done, observe only, and then you can build rapport. After a couple of times, you might be allowed to do one. That's one example. Talking to acute medical teams about whether it's chest or LPs that are done in SDEC, you might again be allowed to observe initially, and then once they see how interested you are, how you know about the skills, the indications, contraindications, and you're well equipped with a good knowledge about the skill, then you might be allowed to do it outside of ED. You can still get feedback of that on your portfolio, and then that allows you to progress. Another thing is to let other people in your department know that you need to do this skill or have this skill done. So that is not obviously just limited to your supervisor, who is ideally the best person to talk to because they're having to look after you, but also know how these skills are achieved in that specific hospital, in that specific department, but also your fellow registrars, any trust grades that have been there in the department, other consultants. I remember from a year ago, one of my colleagues from acute medicine was struggling to get a chest drain done, but he let the ED consultants know, and when a chest drain opportunity did come by, they just phoned him and asked him to come. He had let them know that he's happy to come in at any time to just get it done because it was really essential for him to progress to the next step. Now, I appreciate that this is not ideal. You do not want to be working on your career even when you're not at the hospital, but like I said, this is just the reality of the specialty. I'm not trying to encourage it or support it, but I'm just giving you a realistic understanding of what it takes to get some of these skills done. The second hard truth about ED training, which is again not specific to ED training but can add up to the issues that you might come across, is that you're having to change hospitals quite frequently. Sometimes in the first 2 years of ACCS ED, you are put in the same hospital in all 4 rotations, but more commonly than not, it's a yearly change in hospitals, and a lot of regions are actually quite big, which means the change in the hospitals can be from one area to another being quite a big distance, which will either mean you have to change your accommodation or a very long commute. Now, how can you tackle this? You've got a few options. Either try not to commit to one area if you've not got any family commitments, just knowing that this is the nature of your specialty. Or another is, a lot of people after the first year, they go into less than full time. Now, the faculty is kind of not very strict about this, about the reasons. They are quite understanding in that you have to sometimes go less than full time for many reasons. So that's an option to reduce your hours, make up for the long commutes. The third problem that you might come across early on in ED training is that in your ST2 you have a 6-month block of anesthetics and a 6-month block of intensive care, which means for a whole year you're going to be without exposure to ED patients, okay? So that can be quite problematic when you come back in ST3, in that the transition can feel quite scary. I'm literally at that point at the moment. I've just finished ST2 and I'm going into ST3. A few things that might add to the problem is that you've gotten used to a very different kind of rota. Usually ITU and anesthetics is either sort of on-calls, or you're either doing on-calls on a night shift, day shift, or 8 to 6. Whereas, as you probably know, having applied to ED training, is that ED rotas are very different. They're highly variable, a lot of unsocial hours. So that transition can be difficult. And from what I've noticed from colleagues that I've spoken to, it's usually at that point that some trainees do find the transition very difficult and end up, unfortunately, leaving the training. They leave the training because of a combination of feeling quite uncomfortable coming back to the ED rhythm, the way the patients are treated in a quick and high acuity environment, as well as not having practiced it for some time, plus a difficult rota, plus exams coming up. That can be a combination of reasons. So how are you going to overcome that? One of the things that you could do, you don't have to do this, is to book some ED shifts where you worked in your ST1 year, so that you keep in touch with ED. You're still at least managing your sort of stable patients, maybe get a few resus patients, just to have a continuous feel of your work and get back in the rhythm. I remember when I did anesthetics in ST2 for sort of 4 or 5 months, and I had said I will do an ED shift when the opportunity comes. I remember being quite intimidated when I read on a WhatsApp message that there's an opportunity to do a night shift, and then that made me realize that I should really do it, because it is actually a big problem if I'm feeling scared to go back to my own specialty. Okay, this is quite a red flag, and that made me force myself to actually do the shift, and it was absolutely fine. I mean, you're not going to lose all your skills and knowledge after a couple of months off the shift. It gives you a lot of confidence knowing that when you went back, things were absolutely fine. Okay? Now, another important thing is that you simply have to accept that if you leave the ED environment for some time, even if you are doing some shifts occasionally, when you do come back, you're not going to be necessarily as good on paper as when you left the department in terms of knowing how the referrals are, the management of patients directly coming to you as when you had left in ST. It will just take time. You just have to ride the wave, give it some time, write down what you're missing when you do come back, what you realize that you're missing on, and then just work on it after hours, and then you'll get back soon in. Third thing that you can do, and it does naturally happen quite often, is to do some of your ED exams during ST2. In that year where you're off ED, at least you are keeping up with the knowledge and the skills that is required in ED. So the 3 exams that are usually required in between ST1 and ST3 are the primary, the SBA, and the OSCE. Now, perhaps the OSCE is, because of its nature being a more practical exam, it might be better to do it when you are back in ED. But when it comes to the primary and the SBA, they are slightly more theoretical, so they can offer you the chance to stay up to date with the knowledge that is required for ED, but at the same time you can do them in that year where you're not literally working in the department. The last and important thing to note is that, unfortunately, because of the nature of specialty and not being specific to ED, but you do have to make some sacrifices when it comes to this training program. Some of these sacrifices might include you not getting the annual leave that you want. You might not be able to go on the summer holiday exactly on the dates that you want. Sometimes having to go through studying for exams when there are a few days of really nice British summer. So these are some issues that you might come across. Now, how to tackle them? Planning ahead of time is probably the only thing you can do, and understanding that you can't always control these things, unfortunately. They might still end up happening. So when I say planning ahead of time, I mean things like booking your annual leave as early as possible, bearing in mind that sometimes you might not get it, so anticipating that you might have to swap with colleagues, knowing who might be able to swap with you, contacting them early, sorting it out. These are some things that might help you get your leave, get your holidays, which obviously down the line contributes to you building resilience and lasting longer in the training program without, getting burnt out. Another thing that you can do in planning is to try and have a look at when the exams are early on, and trying to do back-to-back exams during the miserable winters so that you have some good period during the summer where you can travel and make the most out of the summer, and then get back into doing exams in the winter again. So plan ahead when it comes to both your holidays and your exams, and that way you can hopefully get it done how you want it. Now, an important thing to talk about here is that I am in no way criticizing the way the EM training is being carried out. It's actually a relatively excellent training program. Given the difficulties that the departments face, our trainees do get looked after. The deanery does try its best to give us as many opportunities for skills, and if they're not available, they do a lot of simulations. So there are a lot of opportunities to learn. This is just to highlight some problems that you might come across when you start your specialty training and just how to overcome them. I have absolutely no regrets going into this training program, and it opens up a lot of opportunities. So it basically gives you a lot of knowledge in many different specialties, which is not always the case for many of your colleagues in the hospital. It also builds a lot of resilience. You are able to work under pressure, and you're not really bothered by anything that comes through the door. Now, this does not happen straight away. It takes time. I'm still nowhere near ready to tackle such things, but hopefully by the end of training you'll be a lot more comfortable in tackling a lot of things that come through the front door. It also builds a lot of management skills. You're able to eventually run a department and not just see your own patients. Later down the line you have a lot of opportunities. You can subspecialize in pre-hospital emergency medicine, pediatric emergency medicine, or even dual train in intensive care. So there are a lot of good things about ACCS emergency medicine, and even from the very first day, your opportunity to work in 4 different departments, 3 of which are not actually the main department, will give you a very good insight on acute presentations and acute scenarios and how to manage them. So I hope this video has been useful and it didn't put you off applying for emergency medicine or starting it, but just knowing about some of the issues that you might come across and how to overcome them. Wishing you the best of luck.